So now I welcome Dr. Rajesh sir to talk on his topic on subluxated cataract, when to approach from the posterior segment. Dr. Rajesh P is a CMO and head of vitreoretinal services at Abate Eye Hospital, Perindalmanna and Calicut.
Thank you, Divya, for this opportunity. So I'll be talking on when should a posterior segment surgeon or when should a subluxated lens or luxated lens be approached from the posterior segment. I would say this question actually requires only answer in a single sentence because I feel that cataract surgery or cataract surgeons are very skilled these days. They have a lot of tools in the armamentarium with which they can deal with most of the subluxated cataracts. That most of the time the retina surgeon's role is mainly in dealing with a very frankly dislocated lens into the vitreous, which is lying within the vitreous cavity or lying over the retina. So most of the time it can be managed by a cataract surgeon, or when the cataract surgeon cannot do it, that could be maybe the situation where a posterior segment surgeon has to do a surgery from the posterior aspect. So just to define what is subluxation, we know that it is where the part of the lens is still within the hyaloid fossa. It's not completely displaced from the hyaloid fossa, but when it is completely outside the hyaloid fossa, whether it is in the AC or in the vitreous or over the retina, then it is called a dislocated lens. So there are various causes for subluxation. The most important cause that we commonly come across is the pseudo-exfoliation syndrome. Then patients with mature cataracts and high myopia. These are probably the three situations where the zonules can progressively become weaker over a period of time. So these are conditions with progressive zonulopathy, and these conditions you can have a subluxation even after the cataract surgery. Even after a successful cataract surgery, these patients can end up with a subluxated IOL. Then patients who have undergone a prior IOL surgery, especially a vitrectomy surgery, there can be one cause for subluxation, and a very important cause that we commonly see is the trauma. Then, as Prakash mentioned, it could be in uveitis. Then congenital conditions like Marfan syndrome, homocystinuria are all other situations where we see subluxation. So as a part of this presentation, I was very fortunate to see some of the very good videos from the anterior segment surgeons, and thank you, Divya, for the opportunity, because I saw some very good videos about how all these intracapsular devices are used by the anterior segment surgeons. And my idea of subluxation was only confined to capsular tension ring. Now I know that they have got more things like a capsular tension segments, as well as sutured capsular tension rings, which can deal with these conditions. So ideally a capsular tension ring or a standard capsular tension ring, that is the one that is most commonly used by most of the cataract surgeons, and this helps when the subluxation is limited to around 4 hours or 180 degree. When it is beyond 4 hours or 180 degree, a standard capsular tension ring may not serve the purpose. And again, if the patient has got an anterior or posterior capsular tear, if you are going to use a standard capsular tension ring, then there's a chance that the tear can get extended, and that can lead to dislocation of the IOL or the lens. So if the patient has an anterior capsular tear, or the patient is having progressive zonulopathy, as in pseudo-exfoliation syndrome, you should not be limiting it to a CTR alone. We should be trying for a modified CTR, which have got eyelets, which can be which can be sutured to the sclera and can keep the lens in place. So what are the indications for posterior segment approach? As I mentioned, is subluxation more than 180 degree or anterior or posterior capsular tear, where the surgeon is not, the cataract surgeon is not confident enough to use a capsular tension segment or capsular modified CTR like a Sioni ring, which can be sutured to the sclera. That is probably one indication where the cataract has to be approached from the posterior segment. And another important thing is that even when the zonular support is not adequate, as I said in pseudo-exfoliation, the problem is that the patients come back after some time with a dislocated IOL CTR complex. So that even makes the surgery difficult for the posterior segment surgeon, because it's not just removal of the IOL, and we also have to do extra manipulation to remove the CTR. And sometimes this can lead to more complications at the time of the vitrectomy surgery. So whenever you anticipate that there is a chance for future dislocation of the IOL CTR complex, always make sure that it is better dealt with by a posterior segment approach right from the beginning. In traumatic sonular dialysis, maybe that is one situation where the CTR is going to be very helpful, because in trauma, most of the time the sonular dialysis does not progress. It is a one-time insult, and so that is probably one situation where a CTR is going to be helpful. But at the same time, you should understand that trauma can be associated with many posterior segment pathologies. So if the patient has got a subluxated lens, there is dense vitreous hemorrhage, not sure about the actual status of the retina. He could be having an underlying conditions like a retinal tear, dialysis, or detachment. And especially when the posterior capsule is ruptured and there is dislocation of the lens matter into the vitreous cavity, these are situations where it has to be dealt with by the posterior segment surgeon. Then probably there is another situation where the lens is subluxated, it is dislocated or subluxated anteriorly, so that the entire the lens iris diaphragm is pushed forward. There is hardly any space in the anterior chamber. Already there is a lens corneal adhesion or peripheral iris corneal adhesion, where it is difficult to manipulate from the anterior segment. That could be another situation where you can manage it from the posterior segment. Then vitrectomized eye with subluxation, I saw Dr. Laila Mohan madam showing some very good surgeries in vitrectomized eyes. Then there is always a chance for subluxation or dislocation of the lens at the time of surgery in patients who have already undergone vitrectomy, because the cushion that is offered by the vitreous is not there. Another thing is that most of the time, whenever there is a lens touch, you can see those the mark corresponding to lens touch when you examine the patient, especially in the immediate postoperative period. But after some time, when it has progressed into a mature cataract, you may miss that. So if the lens touch is the cause for the cataract, then at the secondary to vitrectomy, in secondary vitrectomy, you should always think and anticipate a positive dislocation of the lens at the time of hydrodissection. So what are the cares, the precautions to be taken by the anterior segment surgeon when dealing with the subluxated cataract? Most of the cataract surgeons, they will not do all these things, but still someone who is starting the surgery can end up with complications like engaging vitreous in the phacophobia. So you have, whenever there is subluxation, there will be some vitreous in the anterior chamber. So if it is not properly dealt with, it can get into the phacoprobe, and pulling on the vitreous in the anterior chamber can cause peripheral retinal tears. So another thing that we often see is that whenever the lens gets subluxated or dislocated, sometimes the surgeon panics. He tries to retrieve it with all the maneuvers that is available, and then the patient ends up with a corneal edema or a striate keratopathy. If that patient is managed on the same day, then maybe we may be able to do a lensectomy and take out the lens on the same day itself. But sometimes these patients are referred from the by the cataract surgeon to the retina surgeon, and the patient may be told that, see, I have talked to the retina surgeon, the surgery will be done tomorrow itself. But when the patient reaches your OP, the retina surgeon's OP, he finds that the cornea is totally white and it is practically impossible to do any surgery that day. So whenever there is a dislocation of the lens, always make sure that you do not do anything that is not in your hands. Just leave it as such, suture the wound if possible, and maybe give the patients anti-glaucoma medications, and also start the patient on systemic steroids. All these will help to have a clear cornea the next day, so that the job becomes easy for the retina surgeon. Then Marfan syndrome and homocystinuria, these are conditions where you see subluxated lens, and they can be managed by an anterior segment surgeon. Sometimes they even put a capsular retention ring. After removal of the cataract, they put the IOL also. There are surgeons who do not do that. They just leave the patient aphakic. This can be done by anterior segment surgeon, but posterior segment surgeon's role is also important, because most of these syndromes, they may be associated with vitreoretinopathies, and they will be having conditions like lattices, which can in course of time lead to retinal detachment. So at the time of lensectomy, If it is even not done by a retina surgeon, it is better to get a retina examined and get all those lattices lasered, because you don't have to subject that side. Most of the time, these are very small children. You don't have to subject the child to another general anesthesia for doing that procedures. So thank you.
Thank you, sir, for that wonderful